Hello, everyone. Good afternoon, good morning, depending on your time, where you are. We want to welcome you to today's Think and Learn. We are sharing from Kenya. On behalf of the Kenyan team, I would like to invite you to this session. My name is Ruben Musundi from the NSDCC in Kenya. Our session is on establishing a national M&D system for the KP program. I want to start by thanking all the countries that have chosen to learn from us through this Link and Learn. We have Cote d'Ivoire, Mozambique, Nigeria, and Uganda. And I also want to take this opportunity to thank the team led by SSLN, Kerry, Lakose, Karabo, Wendy from our region, and Pari for the support they have given us in preparation, the Kenyan team. I also want to recognize our partners who are here to share with our friends and our KP champions from these 4 countries. We have the NASCOP, the National STI HIV and STI Control Program. We have the KP Consortium, and then we also have the Kenya Red Cross and the PEFA team who are supporting us in this learning series today. So with this, I want to welcome you all. I know we have the translators also here. We also want to thank them in advance for supporting us. Kerry and team, I know you always allow us to run the show, but we will invite you at the end to maybe just close for us and share with us the way forward. But at this juncture, we'll go straight to the agenda. Maybe I ask Lakote to share the agenda. We have 3 main presentations today, but we'll start with the opening remarks. And then we go to the main presentation, which is the country presentation on the M&D system in the KP program. And of course, we'll have the presentation from one of our counties. For those from Nigeria, you understand the county system is the way I have the states in Nigeria, Lagos, Kaduna, and River states. For those in Uganda, also have the similar system. I don't know about the Cote d'Ivoire and my colleagues from Mozambique. But we have the 47 county systems, government systems in Kenya, and one of them will be sharing on how we interlink our systems from the national to the county systems. And then we also have our partner, who is the Kenya Red Cross, who is supporting us in the HIV response and even in disaster management in Kenya. So we want to take this opportunity to welcome you all to share from us and even learn with us, and also we'll also learn from you because you are not starting from zero. So with this, I want to welcome our community representative who is on the call, and that is Solomon Wambua, to speak on behalf of the KP, who are our team leads on the ground and also our service recipients. Welcome, Solo, on behalf of the KP community, to give a few remarks, and then we start. Solo?
Yes, thank you very much, Sundi, for that. My name is Solo, or full name Solomon Wambua, from Kenya, and I am the coordinator of the Key Population Consortium. And at KP Consortium, that is the Key Population Consortium, we are actually a consortium of KP-led networks. So with us in Kenya, the key populations are MSM, that is men who have sex with men. We have the transgender community. We have persons who use and inject drugs. And also we have sex workers. At KP Consortium, we actually do work on advocacy efforts to ensure that key populations' voice is actually at the center of the table when it comes to matters advocacy, and also the advocacy for funding towards key populations. And by this, we actually do this by engaging on global fund platforms, like the just concluded GC7 conversations and concept note writing. And our members are presently taking part under the grant making. When we come to PEPFAR as well, we actually do take part in the country operational plan engagement, whereby we actually do give a voice of key populations to ensure that as PEPFAR is planning, they actually know what our key populations in Kenya actually want. And just recently, we did take part in the review of the COP23. So we were actually very happy to see some of the recommendations being put in when it came to the whole conversation on funding for key populations. And also we work with the SSLN community of experts and also our NASCOP, that is where the KP program is actually nestled in. And then also we work with NSDCC in Kenya. And so with that, I would like to welcome each one and every one of us to this meeting. Let us learn how key populations can actually give in their voice into a national process, such as monitoring and evaluation of our programs, because as key populations, we are in the lead of engagement and actually working on our programs. So I would like everyone to just relax, ensure that you get all your answers responded to by using the chat function, and then just type in your name there and also the questions as we continue, and let us learn together to ensure that all the key populations programming in Africa will actually benefit from the Kenyan experience into ensuring that monitoring and evaluation is actually done with key populations at hand. So thank you very much. Over to you, Ruben. Thanks.
Thank you, Solomon, for your remarks and for welcoming us to this discussion. I want to recognize my colleague, John Bao from the NASCOP, who has now joined. John, I want to give you now to take over from there and invite the other partners and even the main presenter. John?
Hi, Ruben. Thank you. My name is John Bao. I'm the KP manager, NASCOP. So, Ruben, I want to say, I'll give my opening remarks, but I will not invite the presenters. You do that for me. So we may have to agree that before. So my name is John Bao. I work at NASCOP. I'm the Key and Vulnerable Population Manager. And one want to say that we appreciate the opportunity that Kenya has all along been a learning platform to other countries when it comes to key populations. And really, us here for our program, we program for the key and vulnerable populations, which includes 4 typologies. That is, for the key populations, we have the MSM. We have the MSM, the PWAD, the FSW. We have the MSM, the military, sorry for that. Something we program for 4 typologies, 8 typologies. For the key populations, we have the MSM, the FSW, the PWAD, and the transgender. The World Vulnerable Populations covers another set of 4 typologies, that is the fisherfolk, discordant couples, prisons, and trackers. So the vision as a country is to ensure that we have a Kenya that is free of HIV infections. And the goal is to prevent HIV infections as well as ensure that for those infected, we provide quality care, that they have quality lives through provision of ART. So in the program, we do combination prevention approach, whereby we have interventions that are divided into 3. We have structural interventions, biomedical interventions, and behavioral interventions. And among the 3, we usually have activities that are geared towards ensuring that we achieve indicators for the program. So really, a lot happens at the ground, and for that, we usually, for the activities happening on the ground, we usually have data collections, and hence now the need to have an M&E framework. So the evolution of the program for the M&E has come a long way. At the start of the program in 2009, data collection reporting was done through Excels that were usually sent to the national program via emails. And after that, we were able to develop tools, and now we have the KHIS. So Currently, we've been able to do a draft M&D framework that we will be using to track our indicators. And so with that, basically that is what we do. There is data collections at the ground. And so I think that with that, I want to, in the interest of time, not to take much. So that is what we have as a program. And so really, it's important that, and I know in Mutuko's presentation, you'll be able to elaborate more on the systems that we have for data collections. So I want to end it there. Welcome all. And I want to declare the meeting is opened. So we are available for any clarifications after the presentations to be able to help others learn from us. So with this, I want to hand the mic over to you, Ruben. Maybe I want to call the presenters, as I alluded earlier. I want you to continue from there, but for now, let us feel free to learn. Let us feel free to ask questions. Let us feel free to clarify. Because at the end of the day, if you have a presentation and people do not clarify and ask questions, at the end of the day, the word learning comes when people have understood and are asking questions. So Ruben, I want to hand over the mic to you to continue, but now the meeting is opened. Over to you, Ruben.
Thank you, John, for those valuable remarks. And we want to welcome all of you. For those who have joined, we are still in the opening session, and I just want to make 2 comments because of time, and then we proceed with the main presentation from Japheth Kioko. From us in NSDCC Kenya, National Syndemic Diseases Control Council, we are driving the Kenya AIDS Strategic Framework, the second one that is ending in 2025, but we revise it to 2027. And one of the populations that we are working with is the key populations. There are 3 areas, what I would call 3 principles. 2 principles and a theory that is common when it comes to M&D. One that we are working in as we work towards ending AIDS as a public health threat in 2030 is the principle of people-centered approach. And then we have the evidence-informed or evidence-based programming. And then, of course, we have the theory of change. All these 3 are now carried by the M&D. And that is why I said M&D is becoming critical in the programming towards ending AIDS as a public health threat. And we are happy that the 3 or the 4 countries would join us in learning so that we all help to improve our SI system. So I know we are not starting from 0 in Nigeria, Uganda, and Cote d'Ivoire, and Mozambique, but we are here to improve as we learn from one another. We know we have set up the M&D systems in your country. You are putting the resources, and we believe that in this learning, as espoused by my colleague John, I believe the 2 or 4 outputs that will come out will be 1, that out of this, we will be able to improve our key population surveillance. Number 2, we'll be able to improve our size estimation in our countries in terms of key population. We'll also improve in care and surveillance and even what we call patient monitoring. And then overall, I believe as countries will be able to improve in what we call using data to improve programs and access to services. So I think after this session, this would be part of the outcome or outputs I would expect we all benefit in our discussions. With this, I want to welcome you all as I take over to our colleague Japheth, who will be presenting on our country M&D systems. Japheth, you can now proceed. Thank you.
Hi, Ruben.
Welcome, we can hear you. I hope my colleagues and all the team members can hear you. They can confirm.
Yeah, so thank you. Thank you so much, Ruben, for that brief. And I think for the welcoming, and I will take this opportunity to take members through the experiences from Kenya in terms of setting up a key population program, monitoring and evaluation system. You realize that it has been a long journey for Kenya in terms of in terms of ensuring that we are able to document or rather to collect data around key populations and also report at the national level. So just move to the next. So the journey in terms of the monitoring and the evaluation of the KP program really started way back in 2009. And as we speak in 2023, we have quite elaborate systems which are used for the purposes of tracking or rather collecting and monitoring key population programs. So you begin to see that in the early formative years of the key population program, there were issues of trying to understand the burden, especially from the key populations. And so there was the modes of transmission survey, which was conducted in 2008. And that really enabled the country to understand the contribution of the key populations to new HIV infections. It's from that study where we noted that 3% of the new HIV infections were coming from the key populations. Also, inclusion of the key populations, the national strategic plans, and also at that period we also conducted in 2011. The country conducted a national, or rather an integrated biobehavioral survey, which was a survey to understand the prevalence of the HIV among the key populations, and also to understand the size estimation. So really, size estimation started with the IBBS, and moving forward, because that was not like a national kind of study. It was only done in 2 cities, but of course used to generalize in other areas. Then we did a mapping and size estimation in 2012, which also augmented the numbers which we were getting from the IBBS of 2011. So really, in that period of 2009-2012, the country really wanted to understand the burden from the key populations and also their numbers and where they congregate or their locations. So with that understanding, then we moved on between 2013 to 2016. Then there was the IP mapping, and IP mapping ideally, because already we knew where the key populations congregate or the hotspots and the areas where they are found. So we started off with now identifying the partners who could be implementing the key population interventions in such places. And from there, after now we were able to identify the partners, then the next thing was to really get a sense of how do we document whatever interventions they have in the different places. And initially, our very first data collection tool was an Excel-based tool. So we developed indicators, both behavioral indicators, biomedical indicators, and also indicators around structural interventions. So with that, then with that Excel, then we shared, or rather we shared the indicators to the different partners whom we had already mapped. And then from there, we started getting data from the partners using the Excel format. And of course, now that the Excel was more of a quarterly based kind of a data reporting tool. So they could email the data to the national program. And then which is now the NASCOP. And then from there, because now we had a sense of how many key populations are being reached in the different areas, so we needed, at some point in 2015, we undertook an IBBS, or rather a polling booth survey, which now was to help us measure the outcomes of the interventions by the different partners in the different areas. So then that means that we had we began to see the outcomes from the interventions, and then using the data which we are getting, then we started also doing the analysis and also sharing the data to the partners so that they can also begin to see where to improve on. So from there, between 2017, 2019, then we now conducted another round of, actually the third round of survey, PBS, the polling booth survey in 2017. And so that polling booth survey also around the FSWs, MSMs, and PWIDs And then from there, we worked around improving, or rather having our indicators in the national reporting system, which is the KHIS, the Kenya Health Information System, where we introduced a module for key populations called the HEMO 731 Plus. And during the same time in 2020, we also did another round of a sense of the new places or hotspots where the key populations congregate. So moving on to the 2021 onwards, now currently we have all the key populations data being reported through the National Health Information System, which is the KHIS. And of course, we also did integrate the key population module in the electronic medical records, which is essentially for client monitoring, or rather patient individually individualized tracking of our key populations, especially those who are on ART treatment. So moving on to the next slide, I think now I will begin to unpack each of these episodes in our journey towards having a monitoring and evaluation program. So from here, I think I mentioned that we really started off with understanding the burden, and we also did the integrated biobehavioral survey, where we now had to see, or rather to see the prevalence of the HIV and the estimates of the key population. So this tells you that we understood our burden through the months of transmission survey of 2008. And then we also began to see the burden in terms of the prevalence. So from this slide, you cannot see that the prevalence of the key populations, FSW was 29%, PWID 18%, and MSM was 18%. And I remember I also mentioned that key populations contributed to like 3% of the new HIV infections in that year. Moving on to the next slide, please. So in terms of the size estimations, remember we said that we have really been doing rounds of mapping and size estimations. The first one having been conducted in 2012. So from here, we are able to tell where the areas where the key populations congregate, and that really helps in terms of setting up interventions, because our initial interventions we are set up in those counties where we found a significant, or rather we found a sizable number of key populations. And so you can see that these maps give you a sense of the distribution of the key populations in the different counties, FSW, MSM, PWID, and also the transgender population. So with this in mind, then we were able to set up targeted interventions or other programs in those areas where populations existed. For example, if you look at the PWID program, you begin to see that we had high concentrations in the coastal region and in the capital city, and therefore our programs really for the PWID started in the coastal region, where we had quite a high number, and also at this, in the capital city, which is Nairobi. For the FSW, then we had really a kind of a uniform distribution. In most of the counties had some numbers for the key populations. For the FSW, although not quite a lot, but also a program started in those counties where those numbers existed. Of course, for the transgender, the first mapping was done in 2020. And so interventions for the transgender really started in 2020. And that tells you the importance of having a mapping and population size estimation, because you begin to see where to place interventions and at what magnitude. So also we did virtual mapping, because we also realized that there was quite a sizable number of MSMs who were congregating in the virtual spaces, and who were not benefiting from the physical-based interventions, the physical hotspot-based interventions. And so that is where we also did a virtual mapping, and we also, and that was targeting 3 cities, Mombasa, Kisumu, and Kiambu. And we found quite a high number as well of MSMs who are not coming to the physical hotspots. And so the need to have virtual-based peer education and mobilization to ensure that we reach also the MSMs in those places. So that is the idea of having a mapping, because then you really place interventions where they are needed. Moving on to the next. Moving on to the next slide. So in the next slide, we also see that, remember we said that after we did the mapping and size estimation, then we did the stakeholder, or rather the implementing partner mapping. So, and we were able to, of course, this exercise was led by NASCOP, and we had simple truths of really trying to understand the name and the conduct of the organization, where they are located, and the population whom they serve, and of course where they get money from. And this really helped in terms of now even doing some kind of allocation of who does what, because we also realized in some counties, or rather in some places where there is a high number of key populations, those areas attracted a high number of implementing partners, like the highest places like Nairobi, Mombasa. And so really we needed to map out and see who really provide services where, so that then we avoid duplication of services, because in areas where there is high number of KPs, you also begin to see a high number of implementing partners, and you also begin to see quite a high number of key populations being reported as having received services. That tells you that there is duplication. So there is need in the mapping phase to ensure that you allocate partners in areas which probably they are specifically responsible for those areas, to ensure that we minimize on the number of key populations who are being reported. So moving on to the next slide, then we are looking at the issue of because at the time when the KP program was new, we are saying that it was important to formally define the monitoring and surveillance system, because in the years before 2012, there was no system. So partners were implementing, of course, in an unstructured way, and they were also not reporting. So they were using their own templates to collect data, and of course they were reporting to the donor. So the government was not having any sense of where key populations are, and who is doing what, and in what numbers. So at this point we had to streamline the reporting. So we defined the indicators. I remember I said we started off with an Excel-based system where we defined our indicators there for the 3 intervention levels. And then from there, we, of course, we started doing the outcomes assessment. The outcomes assessment, so after in 2015, because we had like 3 or so years of implementation, so we need to understand whether the partners, the interventions by the partners are yielding any fruit. So in 2015, we had the first round of 2014, 2015, we had the first round of the polling booth survey. Polling booth survey ideally was to measure the outcomes, or rather to measure the effect of the partners in the different places. So really useful information was provided, especially around issues to do with condom use among the key populations, issues to do with PrEP uptake, issues to do with the injection, whether PWDs are using new needles when they are injecting, issues to do with the methadone, the opioid substitution therapy, STI, and other risky behaviors. So because from the routine monitoring, from the routine reports, you are not really able to tell whether the programs really are yielding the desired fruits, not unless you do a population-based kind of a survey, which now you engage the beneficiaries who are the key populations for them to self-report on the kind of services they receive and whether they are satisfied with the services. So that was the essence of the PBS, just to give us to hear from the key populations on the kind of services they receive. So I mentioned that after we did the Excel reporting, then we now started defining our indicators, which can be pushed to the Kenya Health Information System, initially called the DHIS. So we had like 3 or 4 years of reporting using the Excel, and then at around 2018, the national program transitioned all the key population data into the Kenya Health Information System. So now, under what we call the MOH, all reporting tools under the ministry have an MOH number, a Ministry of Health number, which for the key populations is MOH 731 plus or 731B. So that is currently available in the, if you log in, if you go to the KHIS, you log in, then you'll find that tool, and you are able to access data. So really the Excel-based system was not accessible to many partners, or rather to the government and the many stakeholders. But with the introduction of the KHIS, data in KHIS, then we are able now to streamline and have data available to everyone. So I think I mentioned about the PBS and why we did the PBS, just to monitor the outcomes of the services which are being provided. So essentially, those were the key steps which we undertook at the inception of the program, just to ensure that we are able to monitor and evaluate the interventions. So currently, the government is undertaking the integrated biobehavioral survey. This is a survey which includes a biological aspect, where we are able to tell, or rather to understand, to measure the prevalence of the HIV among the key populations, alongside asking behavioral questions, especially around the questions you can see on the right. So the two approaches, the PBS and the polling, and the PBS and the IBBS, really give insightful information on the outcomes of the KP interventions. Next. So moving on to the next slide, we are looking at, of course, I mentioned that we started off at some point after we did the mapping and the stakeholder mapping. Then we started off with the development of the data collection tools after we had started the Excel-based system. So here we, at around 2017, we started Streamline. 2014, sorry, you can see the blue book. This was developed in 2014. And then it helped partners to report using the Excel format. So 2014 through 2018, this was the booklet which contained the data collection tools. But of course, with the transition to KHIS, we redefined our indicators. And as you can see on your right here, where we have the other booklets. This is a government booklet which contains the data collection tools for the key populations, which is currently being used. So the transition from the blue to the other one was occasioned by the transition from the Excel-based to the KHIS. And as you can see, so we have the national toolkit, which has indicators for the key populations, people who are responsible for reporting, and the periodicity of reporting. And of course, we have the unique identifier code, which also defines establishing a unique code for the key populations. At the time when because at the time of the establishment of the KP program, not many people really understood the KP program. So there was need to have a national training curriculum on peer education, on monitoring and evaluation, just to ensure that we standardize our approaches across all the partners. Of course, to ensure quality of the data, regularly the counties are the national levels. So which are charged with providing health service, of course, with support from the national program, routinely undertake semi-annual or rather annual routine data quality assessment, which is normally done to ensure that each year is done to ensure that to address any to report. So alongside development of the indicators and national data collection tools, we were also strengthening the capacities of the peer educators to do outreach level analysis, gap analysis, to understand which hotspots are not being reached, to understand which KPs are not being reached. So micro planning really helps quite a lot in terms of ensuring that programs are able to scale up HIV services, because then from a micro plan, because the peer educator analyzes and begins to understand the place where services are not being provided and the people who are not getting the services. So this one really helps in terms of scale up of services. Next slide. You can go to the slide on the KP national reporting system is evolving with the time. I think that is where we are. Yeah, exactly there. So I think I've alluded to this, and this is where the journey in terms of the Excel, in terms of the middle one is the HEMO H731 plus. The data tool which feeds into the Kenya Health Information System. So all partners who are providing services really have to fill this tool at the end of the month, and we have a manual, or rather we have an M&D instruction guide which helps them to understand each of the indicators in that tool. So currently we are at around 95% reporting in the Kenya Health Information System for the KP programs. And really, this has enabled the government to have quite a substantial amount of data, which helps which informs in programming for the key populations. And of course, as I noted earlier, we have also added the key population module in the Kenya electromedical records, where we are able to monitor the treatment outcomes of the key populations who are living with HIV. So this is the EMR, which also tracks people who are living with HIV from the general population. So for KP, we also have a module in it. And as you can see, currently we are at around 60% usage. We are still scaling up, and we believe that moving into the future, we will. So we are able to individually track our patients, the key populations who are receiving ARV, or rather receiving medication in the different diocese or health facilities. Moving on to the next slide. We have the issue around the data flow for the key populations. Remember, we said initially we had IP, so the implementing partners collecting data using the Excel tools, but moving forward, we have standardized the tools. So first is that we have the data collection tools in place, and then after every month, the programs or the partners fill the MO731, and then they submit. And as you can see, that blue book is the one which has the indicators. And then, of course, there is the EMR, which also helps in terms of tracking the treatment outcomes. Then from there, after you enter the data into the key population reporting form, the blue one, after every month, then it is uploaded. You can see we have the Kenya Health Information System here. So the data is uploaded. And this one is uploaded at the sub-county level, and then from there, once you submit, then it becomes available to any interested stakeholder. So and this is largely done by the implementing partners who operate in the different sub-counties. Moving on to the next slide is that. Of course, it's important that once data is uploaded into the KHIS, there is need for analysis to ensure that we make use of the data, which now informs decisions around where to scale up interventions and also where to place interventions, especially based on the sub-national units where we don't seem to get data. So in terms of analysis, we normally do the cascades. We have the prevention cascades, where we start with the key populations who are receiving services, to key populations who are receiving commodities like condoms, key populations who are receiving commodities like needles and syringes, and of course, receiving HIV testing, STI, and all that. So that is the cascade we have for prevention, and it helps us to tease out which specific area of our interventions are lagging behind in service uptake. And so largely our denominator in the cascades is now the estimate, or rather the estimated number of people or key populations in those areas. And so we also have the treatment cascades, also, which we look at the number of PLHIV and the ones who are on treatment, and also the number who are virally suppressed. Remember, our data collection tools is able to collect data around the 95 cascade for the KPs. We also have this kind of analysis, implementing level analysis, where we look at the different partners, we look at the counties where they operate, and then we plot this just in a simple Excel format to see which areas different programs are lagging behind. So you realize that whether it is for prevention or treatment, whether it is outreach, whether it is clinical, then we're able to color code and say this partner in this county is having a red around condom distribution, is having a green around peer education. So that means probably they are saying they are reaching peers with education, with education, but really we don't seem like we are distributing commodities as per need. So this kind of analysis helps to tease out specific programs where issues are emanating from, and also where things are going well. Also, we have a national subnational dashboard, and this is a dashboard. As you can see, we have the filters for the counties, so we are able to tell. This was initially when the program was actually starting. We had this kind of Excel-based dashboards, and so we were able to tell the performance of each of the counties across the time. Moving on to the next slide is that, remember I mentioned that key population programs, in key population programming, there is a tendency of over-reporting, especially in areas where there is there are many partners who are concentrated. And so one of the objectives, we did a unique identifier code just to ensure that programs are able to register KPs and assign them numbers, and those numbers were to help in terms of uniquely identifying them. So once a peer educator is placed at the hotspot, then any new key population member who is coming in, then he's assigned a number using this algorithm. And the number is assigned to ensure that one, he gets formally registered in the program. And number two, it helps in tracking each KP across the cascade, because then we are able to associate, because different KPs many times or sometimes would have the same number, or rather the same name, would be using the same name. And so if they are using the same name, you may find 3 people with the same name. So you may not be able to uniquely track each based on their service gaps if you don't have a unique code. And then, of course, number 3 is that the unique code also helps in anonymity. We don't want to identify key populations with names, but essentially for the service providers, they identify them with the ID, so that then you don't have to make reference to the name of the person, of the key population who is getting the services. And of course, it was the UIC is also used to link the KPs to the especially the ones who are receiving NRT. So the code is based on the location and on the demographic profile of the KP, and also through the routine serialization. So in terms of the location identifiers, we normally use the county, the sub-county, the ward, and of course the implementing partner. And this helps to know the location where the KP is based, the sub-county and the ward, and from which implementing partner. Where we have the ADT, that is the partner who, for this example, this is an example, the partner who was providing services to this key population. Then we have 001, which is now the hotspot code. And then we have hotspot code, because hotspots are also serialized, and then you begin to follow them. And then we have 01. We also follow them by the KP type. So we are able to say, this is SW, this is MSM, and this is PWD. Then the one where we have the JHO, ATOM, those are the first two initials of the three names. So we need to get the names, but now from the names, we extract the two names, the first two initials of the names. Then we also pick the month of birth and the KP serial number. The serial number is from the master register. There's always a master register. The master register enlists all the KPs as they enroll in the program. So it means that if you're number 001, you are the first to be enrolled. So the UIC really helps in terms of tracking the KPs and ensuring that individually we are able to monitor them. So moving on to the next slide is that in terms of so remember we mentioned that we have the polling booth survey. Just move on to the next slide, where basis to monitor the progress and to make changes. So as you can see from this slide is that this is a polling booth survey, and a polling booth survey is a survey which is done among the key populations at a group-based level to provide interviews and then extract answers on very sensitive information. Because we realize a face-to-face interview with the key population sometimes, or many times, you are not going to get the right responses, because the one-on-one engagement with the interviewer really does not augur well with them. And for the specific, or rather for the highly sensitive information, they may not provide. So the PBS is an innovative way of ensuring that, one, the key populations are able to provide answers or other responses to highly sensitive information. And number two, that because it's a group interview method, then we expect that there's a high likelihood of getting the correct answers. So this is one of the biggest advantages of the PBS as opposed to the face-to-face interview. So in Kenya, the PBS has been implemented in I think in 3 rounds. There was the 2014, 2015, and 2017. So in those, so from the 3 rounds of the polling booth survey, then we have been able as a country to measure the effect and the effect of the interventions in the different places. And it is a simple method. You just place the cartons. You have a carton which acts as a booth. You have some what do I call them? Some lunch boxes, one green, another one red, another one white, where the respondents, the KPs, will place their responses. If they are agreeing to that question, they normally put in the green. If they are disagreeing, they put in the red. And if they are non-committal, they are neither yes or no, then they put on the, or rather, if it's not applicable to them, they put on the white box. So it's a pretty simple approach, which helps partners, or rather the national program, which helps the national program to understand. So it's really simple, and it has been
Kyoko, we need to conclude.
And as the reader, or rather as the interviewer goes through the questions, then they drop their cards. There are cards which are serialized based on the question. So if it is question number 1, it is card number 1. So they will drop the card number 1 in the respective box. And then, of course, tallying is done at the end, where we're able to say for question number 1, the number of years were 10, the no's were 2. So it's a small group, like 10 to 12 people, or 10 to 12 key populations. Because again, we don't want to make it a large group. Next. So looking at the next slide is the issues of coordination, and coordination really means that you have to bring every stakeholder on board, and of course led by the government. So for the key population program in Kenya, there are quarterly TWGs. Of course, the coordinating mechanism or body is the technical working group at the national level. So they meet on a quarterly basis, and essentially they meet to assess the progress of the interventions in the different areas, and also to see probably the challenges which might be coming up from the implementation. So within the national TWG, which brings different stakeholders from the government, the implementing partners, and the donor community, and of course the key population community, then we have an M&D subcommittee which also meets on a routine, or rather on a regular basis, just to see any issues coming up around the implementation of the M&D framework, and also in terms of scaling up the reporting rates, especially now that we also on the Kenya EMR, which is at around 6%. So the M&D subcommittee is really address issues around the monitoring and evaluation in terms of data collection, in terms of quality of the data, especially they also begin to assess the reports from done, and that helps in terms of zeroing in on where specific places where there seem to be problems. So moving on to the next slide, and we are looking to the future. And so we have, of course, we understand that for the key population program, initially, or rather even initially, we looked at the four main key population types, which are the FSWs, MSMs, PD. So initially, these groups were not included in our initial monitoring and evaluation tools. And the beginning last year, we have developed monitoring data collection tools for the vulnerable populations, and so trying to step, and also focusing and visualizing and strengthening the system at the county level for the KVP, including the vulnerable population. And of course, data quality, we continue to ensure that the quality of the data is improved through routine RTQM. And also it is important that capacity building continues, or rather becomes an ongoing activity, just to ensure that if there is any change of staff, and then the programs are able to transition well and continue with the implementation. So I think with that, I seem to have come to the end of my presentation, and so I'll take it back to Ruben. So thank you so much.
Thank you, Japheth, for the presentation. Just to assure our participants, I think that was the major presentation. The rest will be very brief. And also to inform the team that we have a bigger team that is working with us, Japheth, Memory, Jaffred, and even Timothy. I think most of us have interacted with them in the various sessions. We want to request Memory kindly take up the questions that are being put on the chat, so that when we go to the Q&A, we can quickly start with those ones. So at this juncture, I want to invite our colleague from the county system now, Robert Kinoti, to present on how we interact with the data at that level. Robert, where there is an area Japheth has mentioned, you can just pass and then emphasize on the other areas. Thank you. Provide, we move forward.
Thank you, Ruben Musundi, and my previous presenter, Kyoko. This is Robert Kinoti from Meru County, one of the counties in the country, Kenya. Those who know the geography of Kenya, Meru County is placed about 220 kilometers northeast of Nairobi, capital city. So I'll just go straight to I'm a health information management specialist, and basically I'm at management level in the county. and therefore I'm here to represent the county on this forum, where other counties can learn from us what we are doing. So quickly going to the presentation, I think my previous presenter has just spoken about these key vulnerable populations, and currently we are monitoring the 7 of them: female sex workers, MSMs, MSWs, PWIDs, people who use drugs, transgenders, that is either men or women. And of course, now, currently we are reviewing our tools. We have actually reviewed our tools to incorporate the vulnerable populations. And these include the fish folks, trackers, people in prisons, discontent couples, which we shall start monitoring very soon after we roll out the new tools that have been revised. So next slide, please. So one of the most important things is that for us to be able to ensure that we are able to get good or representative outputs of our population is to characterize it by disaggregating our populations by age, by sex, as well as the population types, whether key populations and or vulnerable populations. And then ultimately, we shall be able to get the various outcomes and do targeted interventions to all these populations. Next, please. So basically, yeah, I'm sure this slide shows the flow of key and vulnerable population data collections. And on the first column, you can see the services. We have categorized various services. The first one is registration of KPs in the program. And this one is actually the one that measures the actual first contact of a key population into the services that are provided either at the community or at the facility. So our structures are that we are able to register new key populations, that is, as it was mentioned earlier by Kyoko in the hotspots, as well as also in our health facilities. We have what we call drop-in centers. These are drop-in centers which are assigned, either connected to a certain facility within our levels of healthcare provision in our health facilities. And of course, Kyoko was able to mention that we are able to generate unique identifier codes. So we normally use various forms for search and for registration of KPs. We have contact forms and also enrollment forms. When they come to the program, we are able normally to provide them with behavioral interventions. And remember, for M&D is basically, we talk of documenting each and every service that is provided by the provider. So basically, we need to ensure that we are able to identify the service, and then we are able to know the processes of documentation that are involved. For example, the second one is behavioral intervention through peer outreach, and there we offer behavioral messages, referrals, and also they also provided commodities, and this is through our peer outreach services. And that documentation is normally filled in a peer outreach calendar, whereby each peer is able to maintain a calendar of the persons that are normally provided services. And we have also our outreach workers who also get the summary reports from the peer outreach workers, and they report for that level. We also provide provision of clinical services to our key populations. And one of them is we are able to, the processes involved in documentation provide the clinical services, including STIs, HIV, and other health services. And we normally fill the related clinic forms. Same for structural interventions. We have key populations who, apart from getting the other health-related services, we also provide other social protection services, whereby we can be able even to refer for those who require various documentation tools. There are those who come with having been violated, they're also being provided services, and those specific forms are normally completed. We also manage the commodities, and of course, all our providers, either at the facility level or the outreach level, they will normally complete various documentation tools, as you'll be able to see in the next slides. And we are able to track how is the availability of these commodities in terms of stocks, and how they are being issued out, the tracking of their movement, those that are coming in, issuance, and also at the end of it all, what are the balances that are being reported onwards. Next slide, please. So after doing all that services, all this information from the various tools that we manage, all this information is summarized in what we call a KP court register. And this KP court register, currently we are having one control register that captures all these indicators. The purpose of this register is actually to monitor the outcomes within 1 year for the KPs that have been enrolled in our services. So basically, this is one key important tool that will help us to know how the program is progressing, whether successfully or not, because this is where we shall monitor the ultimate outcome of either roster follow-ups, those who leave the program, the various prevention or reduction measures that we have, interventions that we have provided. At the end of 1 year, we're able to measure what are the outcomes. So as Kyoko had indicated, there are two main tools that are managed now to report on all these data elements or indicators that are being reported by the various tools. So we have what we call an MOH 7.1 plus for key population. And for the one for the commodities, we have the DHIS. We have the FCDRR for commodities for key pops. So next slide, please. Next. So I'm going to mention some of the standard operating procedures that are usually in these tools. Our healthcare workers usually have, they are normally, as Kyoko has just mentioned, our healthcare workers are normally taken through some trainings, and one of the main aspects is on the M&D tools. For these M&D tools, for them to be standardized, there are narratives that are normally in those tools that provide a description of the purpose of the summary brief of the description of these tools. What is this tool all about? Who fills it? When they meet a KP, in that interaction between the KP and also their service provider. So it also shows where it is filled, where it is placed or filled, and by whom. And the purpose of that tool is normally indicated very well. The frequency of filling these tools, you'll be able to see that we have quite a number of these tools that are being managed by our program, and also the variable instructions that are normally given. So for each tool, there is a variable, and there are instructions for each variable that is being monitored. And of course, there are some other instructions about where this tool needs to be stored, and who is the custodian of these tools. Next slide, please. So what I'm providing here next is the various categories of tools that we are having and I will not be able to speak to each and everything, but you can see one of the categories of the tools is community outreach tools. We have the content form, and this is the first tool that is normally completed on the first encounter with KP in their setups. So normally it's filled once, and the people who fill it are the peer educator or a clinician or a HTS provider, depending on the setup that these KPs are found. We have the peer educator outreach tools. So in this category, you can see you have about eight type of tools. Peer educator outreach workers, summary sheet, hotspot listing tool, peer educator follow-up tracking. This is important for especially monitoring those peer educators who are supposed to be providing services, and sometimes they get lost to follow-up. So we need to maintain a follow-up of these peer educators. And when they are lost to follow-up, there is also another tool that is normally completed to confirm this peer educator has actually been out of the program as a lost to follow-up. Then there's a peer educator or outreach worker overdose encounter reporting tool. Then there's a referral register for social protection services, and the frequencies of how they are completed and by whom are normally the instructions are normally in those tools. The next slide. The other category of tools is the clinical tools. We have the clinical enrollment form. Immediately the KP is enrolled in a program, then the clinic enrollment form is completed once they agree to be in the program. And of course, you can now see the frequency of filling these tools and by whom. Most of these clinical tools are normally completed by healthcare worker. Other tools are like the clinic visit form. You have the STI treatment data collection form, alcohol abuse screening tool, patient health questionnaire. This is a questionnaire that has about 9 questions to screen about depression. You know, some of our KPs suffer from depression due to various factors, and this tool is one of the tools that is used to assess to what level of depression and are they suffering, and the intervention is normally identified looking at the level of assessment that has been done, or the results that is provided through the assessment. Then we have the healthcare worker overdose encounter reporting tool. Next, please. The other category of tools is program level tools, and our KPs also are provided services related to various events that happen to them. For example, a KP might be violated while providing their services out there in the hotspots, and normally such a form is normally completed. So we have the training summary tool. This is for the persons or the health workers who have been trained in various aspects or various modules or courses related to KP, and that database is also monitored. We have also a KP code register, and this is the one that I mentioned earlier, that this is the one that all the services, some of the aspects of the various services that have been provided to the KP, they are normally captured in this code register, which monitors their outcomes after 1 year, but they are normally completed on monthly basis and specifically by the M&D staff. Next, please. So we have also a category of these tools that are commodity based. We have stock cards, which more or less is referred to bin cards. And these are normally completed or are kept in the facility. and they are normally completed on event basis whenever those transactions of either issuance or receiving of commodities within a store, maybe in a dice, and that is in drop-in centers by a pharmacist or a clinician. We have other forms of tools like a counter requisition and issue voucher, and this is the ones that are used to either issue out commodities within the department, within a facility, or to other facilities. Then we have the facility data activity register. This is an activity register that captures all the transactions of prescriptions or commodities that have been provided to the KPs at the facility level. And normally they are filled on daily basis by a clinician or a pharmacist or a storekeeper. Then, and this actually monitors at the unit level how the commodities are moving. The other tools monitor the commodities at the store level, but this one monitors at the patient level, the commodities that are issued to the key populations, and they are normally entered in that register. The other one is a facility issuing register for condoms, lubricants, and needles, as well as also syringes. And the last one is a condom outreach register, which is normally filled on monthly basis by the program officer. Next slide. Lastly, we have those two now main tools that ultimately summarize all the information captured in all the other tools. For service-related services, the tool that we document or report on is a key population reporting form, MH7.1. This is mostly in hard copies, and it is normally entered, the monthly report is normally entered into the KHIS, information about software. KHIS is the other version of the District Health Information System, or DHIS2. But in our country, we have embraced now KHIS. The other tool is now the commodity one, which summarizes all the commodities that have been provided for the KPs, either at the facility. This one is able to monitor the stocks, stock levels, the balance, the ending balances in the facility, the open balances, the issuance, the adjustments, and all that. And it's normally, these two tools, they are normally like this. Sorry, I'm outside where it's a bit windy. Then, of course, for the first two, the MH7.1, in our setup in the counties, KP program, all the reports are normally submitted to the sub-county. Our levels of administration, we have the counties, we have the sub-counties, which are lower levels than the counties, and then we have the facilities. So normally, the dice are normally within one of the sub-counties, and we task our sub-county officers at each sub-county to actually manage these tools, and they are entered into KHIS at that level. So next, please. So this is how our systems organization of health services is managed. At the lowest level, we have the community. We provide community services at that level. And also at the facility level, we have the facilities which are the bulk of the reporting or service provision area, as well as also first level of reporting. Then second, we have the sub-counties. These are consolidation levels where, for example, in my county, Meru, we have about 11 administrative sub-counties, which form one county level. So, for example, in the level that I'm managing now at the county, I normally expect about 11 reports from my county every month. And as Kyoko said, this is one of the aspects that we monitor in the county to ensure that every unit is reporting 100%. At the county, that's where the program management coordination issues are normally done. Issues of monitoring or providing technical assistance to the other levels, like the human resource trainings of healthcare workers, distribution of the tools to the various levels or units, and ensuring that these people are also submitting their reports to the county. These reports are actually monitored and evaluated at this level to ensure that there is the targets that have been set, we are able to meet them, including completeness and the quality of the reports that are submitted from the lower levels. And from county to national and programs and national programs and partners, they're able to access this information through the KHS. Next. About to talk about the implementation, evaluation, and the financing mechanisms. These are just missions that have been put in place to ensure that our level, at the county level, as well as also in partnership with the national and also partners, we are able to ensure there is a sustainability of the information system. So looking at our institutional structures, we have the administrative and the devolved governments, and whereby myself, I sit in the devolved governments, that is the county governments, and our main role is supervision on data management processes. That is the issues of data collection, data analysis, reporting, dissemination, and also making other decisions with this information. And the most important thing for us critically is to ensure that we are able to provide the data collection and the reporting tools as they are designed and availed to us from the national, because the national has the responsibility of standardizing all these reports and then making sure that the other technical aspects like capacity building are monitored and they are adhered to. So specifically spoken about the roles and responsibilities, and we cannot do this one alone. We have partners in place, like we have our stakeholders, we have our local implementing partners that we engage whenever we have some gaps. If we want to strengthen our health systems, these are the partners that we normally hold meetings, regular meetings, planning meetings, and also review meetings with them so that we are able to address some of the gaps that we are facing at the county level.
Robert, you need to conclude. Thank you.
Yes. Next slide, please. So one of our main stakeholders is the general public who have to seek services, including the KPs. We have other players like the faith-based and private faith-based facilities. We need to work hand in hand with them so that they can also provide comprehensive picture of what is happening within the health sector. Now, on the M&A mechanisms, of course, we have to work within our stipulated M&A frameworks. We have to have our plans, we have to have our budgets, we have to know our objectives, and then what we need to implement. All the activities that we have identified and monitor them as stipulated in our M&A framework. Next, please. So the other thing I might talk about is that eventually at the end of each year, at the end of every lifespan of our plans, we normally have what we call annual work plans, and also we have strategic plans. And for each project, this document is very important. We need to have a M&D framework that at some point we are able to monitor what are our achievements, what are our performances in terms of the objectives, in terms of the implementation, and also at the end of every 5 years, we are able to review these documents again to reassess whether there are new information that can be included in the new strategic documents. Next, please. I cannot leave mentioning about M&D without mentioning about financing mechanisms and our expectation, the support that we need as health information to support our sustainability and functionality is we need at least 10% of the health budget allocation to support M&D activities, because we have the human resource, we have the infrastructure, we have the equipment. So this is to speak that we have challenges that as despite implementing the KP program, we have challenges with human resource, with the infrastructure, with the systems, the EMR systems that we are using. They are not, the coverage is low. So therefore, going forward, at least 5 to 10% allocation to M&D activities is very crucial for a well-functioning M&D or HIS units. Next, please. And I think that's all. And I thank you very much for listening to me.
Thank you, Robert, for your time and even taking us through the county processes in the KP program monitoring system. I think our participants are now able to build up from the partner, implementing partner, to the county level system and to the national system as had been espoused by our colleague Kioko. So I want to invite Gordon. Gordon, I will give you 7 minutes because of the session on Q&A. We want to give you sufficient time. So I know you can do it. So I want to welcome you. And as Gordon comes on, I want to invite our translators to help us translating some of the chats. I can see they are in French, so that we understand the question. Thank you. Gordon, proceed.
Thank you, Ruben. Thank you, Kioko, and thank you, Kinoti, for highlighting some of the M&D systems that we have. I think I'm coming in as a partner supporting Global Fund Grant. And first and foremost, my name is Gordon. I lead the M&D processes for Global Fund Grant. So I'll take you through a brief of what data collection and reporting structures are for Global Fund, and also how we feed into the national system. Next. So first and foremost, we want to just introduce Kenya Red Cross. Kenya Red Cross is a national humanitarian organization which is established in through the parliament, and that's under the Kenyan law. Our vision is to ensure to be a leading humanitarian organization, sustainably promoting the well-being, health, and resilience of communities. So for now, we are the principal recipient for the civil society organization, and with a coverage of about 46 counties out of the 47 counties that we have internally. And we work hand in hand with about 65 organizations to implement Global Fund grant. Next. So under the Global Fund grant, the overall goal is to contribute to the attainment of the UHC coverage, or UHC through comprehensive HIV prevention, treatment and care for all people in Kenya. So those and this you can appreciate that this is removed from our cash to Kenya Aid Strategic Framework 2 that every partner is striving to realize. The objective of the grant is to reduce new infection by 75%, AIDS-related mortality by 55%, and also HIV-related stigma and discrimination to less than 25. I know we are really striving to also reach out to the UNAIDS goals of 10-10-10 in our country as well. So far, we've managed to enroll so many key population clients. We work with MSM, we work with FSW, we work with PWID and TG. And recently, we also started an implementation strategies on other vulnerable populations that were talked about, the fisher folk, the trackers, as well as the prisons as well. So, and the community resource persons that help us to do this work include the peer educators, the outreach workers, and paralegals as well. Next. Next. Sorry. Okay. Before I take you through the visualization on the processes of the flow of data collection and reporting for key population implementers, I would want us to appreciate where this is coming from. And I think to my colleague Kyoko, who mentioned that we do mapping and size estimation, which gives us data and information to be able to conduct targeting, effective targeting across the different counties. So it means the interventions will be more going towards where we have more population according to the size estimate. And we use this to be able to also provide targets to those counties based on the numbers they have. And it is from that the different organizations that we work with conduct the hotspots validations to be able to validate these numbers that have been captured in the size estimate. And once the validation is done, then the process of hotspots listings begins and the selection of the peer educators. And it is through there that now, through peer education, they can be able to start enrolling, identifying these plans and enrolling them through a process where they can be able to use the contact form. And this is also used to be able to screen, because they do not want just to enroll anyone that is in the hotspot, but the people that they get contacted with are screened, and to ensure that they be able to meet the threshold of KPs before they can be able to be enrolled. So once the enrollment is done, and we are looking at the picture on the left, the peer educators are able to provide peer education at that particular level, and then refer these particular key populations to either the DIC or through the outreaches that are always done at the hotspot. And through the hotspots as well, sorry? Sorry. So the peer educators are able to provide referrals to people to clinical services, either at the outreach or at the DIC, which is a static kind of implementation effort. And at the DIC or the outreaches, adequate clinical service provisions are given, and then the records are taken. And it's from there then they be able to fill in the forms that you are taking through by our colleague Kinoti. So our organizations or the services that we fund are able to fill the forms and to fill also the valence form. And then at the lower level where we are supposed to fill the key population of court register, we have different, we have the M&D officers or data officers who uses the data forms that have been filled at various levels, at the hotspots level by the peer educators, at the outreaches using the outreach tools, at the DIC using those clinical forms, and also at the program level for those structural interventions to be able to fill in the key population court register, which was presented by Kinoti. And he mentioned that this is a master KP tracker that documents all the KP registered and conducted in the program and follow them through to a period of 1 year. So once that is fully filled, then the summary is developed and reported through the KDHS and also using the MOH 731. So if you look at the structure on the left, on the right, this just gives you how the data flows from the peer educators to the sub-recipients that we work with, to our regional offices at the same time through the government structure, so that the MOH 731 can be transferred to KDHS, as was mentioned. So that is how we can be able to the data flows from the hotspot till the headquarters, where we can be able to use this information for decision making and to ensure where there are problems, the challenges are addressed within the shortest time possible. Next. So normally, before we use this data, as we collecting, there are a number of issues, and the key questions that we always ask ourselves is this data data of quality that can be shared even with other partners. So there are a number of mechanisms that are put in place to ensure that the quality of this information is met, and also to ensure adequate storage, and even to ease the retrieval processes. So we do this at different levels. We do this at the organization level, which we are saying the sub-recipient level. This is also done at the regional level, where we have the regional staff who manages or coordinate a number of clusters, a number of SRs within a cluster of counties. And then we also do this at the headquarters level, where we can be able to provide feedback to the reports that we are receiving through the SR or the sub-recipient. And then once that is agreed upon, then this data is stored and used for decision making. Next.
Gordon, finalize. Thank you.
Next, the last slide, I think. So normally using this system that have been elaborated by our colleague Kyoko and Kinoshi, we've realized a number of what I'm calling key achievements for the program, and making it the program more efficient and effective to track interventions, and also to inform programming at different levels. We support to ensure operationalization of key size estimates, because this is what informs the programming to know how many people are we working with and where are we. We also support to ensure standardization in terms of those national tools that you've been able to see, and we've been able to ensure the implementation guides are standardized across all the implementers through the utilization of the unique identifier code that was mentioned by my colleague Kyoko. We've also ensured that the data that is generated through the system can be able to provide timely information for prevention cascade, treatment cascade, and even a report on data elements that are needed for programming. We also ensured through a joint kind of process, ensure data quality across all levels at the organization level, at the hotspot level, and even at the national level, where the data is done through a number of strategies, relying on RDQA, providing data review feedback, and supportive supervision. This has also enhanced documentation and dissemination and publication as well of some of the good, the best practices, and also lessons that we are generating from the implementation. We've also ensured to provide feedback, continuous feedback to the beneficiaries themselves through establishing a toll-free line to be able to support this key population, especially whenever they want to report certain complaints and things that really require our immediate action. And lastly, the information that we generate has always helped us to be able to implement the prevention outcome monitoring, to be able to see where the program is going, whether we are really in track on what the objectives of this particular grant and also the results that are expected. I think that was the last, and thank you so much. And back to you, Ruben.
Thank you, Gordon. I think you took a few minutes, but I think you've done well. Participants, we have about 23 minutes to go. So we want to give the 20 minutes for Q&A. I know there are some questions you had put on the chat, and I have seen some responses, but there are others we need to discuss as we move forward, as you seek clarifications, and even as you ask any question for the participants. As I mentioned, we have a bigger team here that can support Kyoko, Gordon, and even Robert to finalize on our discussion. So I want to give to my colleague Memory to take us through this session, and then I'll just come in the last 2 minutes to finalize. Thank you. Welcome, Memory, and take us through this Q&A.
Thank you so much, Ruben. I hope you can hear me.
Yes, we can hear you. Kindly proceed.
Yeah, so I think the questions that were asked, the first question was by Dr. David, and he was asking about whether if a KP moves to another county, then you are able to change their UIC, and I think that has been responded to in the chats. There was also another question on whether it is possible to visualize the UICs of the key populations across the implementing partners, of course, at the national level. And that has also been responded to in the chat, unless further clarification is needed, especially on the fact that we also have the Data Protection Act that you are working, that is guiding us as a country. The other question was in terms of also measuring the HIV education among key populations. And for us, of course, as a program, when it comes to measuring the program outcomes, then mostly what you do is the polling booth surveys that we conduct, as was shared by Kyoko. There was a request if the key population, there was a request whether the team could access the reference guide for the key population, that is the key population tools, as well as the data collection and reporting tools themselves. And that has, a link has also been shared in the chat where you can access them. Maybe you just need them for guide and to support you when as you do your MID system. And then the other question, I think, was on whether we're able to use UIC in terms of understanding the intersectionality of the key populations. And Jeffrey will maybe respond on that. So those are the ones that we mainly captured, which were in English, but we also saw some few questions that were in different language, and will request if maybe they are translated so that you can respond appropriately. Thanks, and over.
So we give Jeffrey to respond to that, and then we. Jeffrey, you can take up that question, and then we.
So Ruben, confirm you can hear me. Yeah, so in regards to UIC being able to help us understand intersectionalities, currently that is not possible because our UIC codes are for specific KP typologies. So for example, if you have someone who today is an MSM and tomorrow they're transitioning to become a transgender, then that would mean that we need to regenerate the UIC codes afresh so that we can be able to expand the previous UIC codes. So currently, we are not able to do that because the way we track our KP program is in respect to the different KP typologies. So one person might not be able to cross over from one typology to another directly. unless we are able to change the UIC codes as per the way our UIC codes are allocated. Thank you.
Thank you, Jaffred. Memory, you take a few questions and then we finalize.
Jaffred, it's been indicated that you need to highlight how you record the overlapping risk amongst the key populations.
Yes, we can hear you. Please go ahead with your question.
Merci, nous voulons dire merci à cette présentation vraiment avec beaucoup d'apprentissage pour tout ce que nous avons vu au cours de cette présentation. Ma question, c'est je voudrais juste présenter notre contexte et puis avoir le conseil de l'équipe du Kenya. En fait, nous, on a encore au fichier Excel pour la collecte active des données sur les populations clés au niveau des partenaires d'implémentation. On a essayé à plusieurs fois d'intégrer ça dans le DSH2, mais on n'a pas encore eu l'accord de la... Le souci, c'est que eux, ils veulent que les données soient renseignées à partir des centres de santé, c'est-à-dire que des communautés autour des centres de santé, alors que les partenaires d'implémentation disent qu'il est plus facile pour eux de rapporter à partir des districts. Bon, chez vous, vous les appelez comtés. De faciliter à partir des districts. Mais ils disent que pour pouvoir assurer une vérification de la mise en œuvre réelle des activités, des interventions, il faut que les données soient rapportées à partir des centres de santé, c'est-à-dire les sanitaires. Donc, jusqu'à présent, on n'a pas pu convaincre la direction de l'information stratégique pour pouvoir intégrer, ce qui fait que on continue de collecter avec les fichiers Excel par les partenaires d'implémentation. Quel conseil ou bien quelle orientation pouvez-vous nous donner pour qu'on puisse convaincre la direction de l'information stratégique pour accepter que les données soient renseignées à partir des districts pour faciliter l'activité des partenaires d'implémentation? Merci.
Tim, I hope you have clicked on the translation link and you could be able to hear the question. Jaffred, Memory, and Tim. Kyoko, if you are still in. Were we able to hear the question, translation?
Ruben, no. Maybe if someone can be able to just give a summary of what that. I think my icon is not working.
Okay. I can ask him to repeat and then Hello? Jaffred? I think I heard the last bit. He was asking the country they are still using the Excel. You remember Kyoko explained how we moved from that to a consolidated system, and he's asking how can they convince their management to be able to adopt the same process. I think so. I heard part of it. I hope, translator, you can confirm if I captured it well. And if there is any part I have not, so that we answer that and move. Yes, I can hear you. Yes. Mm-hmm. 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 Okay, I get it. And then the other one was about how they can move from the Excel sheet, a manual, to a more integrated system. How can they convince them? So team, I hope you can hear. The first one was their management requires that they obtain data from the health facility. Data collected from health facility.
Yes, Ruben, allow me to go in first, then maybe my colleagues might come in.
Yes.
I think what that questions for me, the way I would respond it is that for us, we have a very robust kind of system. I know there are two types of implementations. There are those organizations that implement in the community through an outreach, and those that have the DIC. And I would explain them this way. Through the outreaches, they conduct the outreaches with the help of staff from the health facility. So it means whenever the outreaches are conducted, there are some new information that goes in to the health facilities, facilitating consolidation and reporting through that channel. The other bit of the DICs is that in Kenya, most of these DICs are registered as clinic, meaning they can be able to report, and they have the MFL, Master Facility List code that gives them authority also to report through the national system. So through that also the data is translated and can be captured to those DICs. But in terms of maybe moving from the Excel to the system and also maybe adopting the national level system, I would want to say that maybe our constitution gives us the opportunity to be able to provide health services to everybody without discrimination. So it means that if we have this health information data and the government has like an integrated system to capture this, then it is very easy for you also to integrate that into this, because this, as much as we are implementing key population, most of these are health services that we are providing, and the country has a national system that captures information and be able to report on those services that are provided. So for us, the opportunities, our constitution that provide that leeway. Thank you. And back to you, maybe to my colleagues to add on what I've left. Thank you.
Yeah, thank you, Ruben. Probably I can also add on to.
Thank you, Kioko. Welcome.
To what Gordon has said, especially around the transition from the Excel-based system to the KHIS. And I think one of the things is that even the Kenya Health Strategic Framework recognizes key populations as a priority population of focus. I think because of the months of transmission study which was done some time back, I think 2008 and also in 2020, it really showed the contribution of the key populations to the HIV landscape. And that means that with that data, then and also having been recognized in the Kenya AIDS Strategic Framework, which is a national policy document which guides HIV implementation in the country, then of course it was not really. I mean, the government itself at that point has really appreciated that we needed to have KP as part of.
Kioko, are you still on?
You can hear me?
Yes, I can hear you now. You were.
Oh, sorry. I was saying that because of the inclusion of the KP in the framework in the Kenya strategic framework, really also gave some impetus to the whole discussion around mainstreaming the key population data. And number two, I think the government and the civil society, the implementing partners, really have been engaging all along. Remember, we have said that the TWG, the coordination mechanism in Kenya, is very strong, and it has been working ever since the key population program started. So through continuous engagement between government and the civil society, then it also becomes easy for the government and the civil society to agree and have a common platform, because also government needed the data to track their HIV framework, the CASP. So I think based on those discussions, where do you get data from? How do you now really monitor your M&E framework if really you are not able to report on the key populations? I think that is why really it became possible for the key population data to be anchored in the national MIS platform for health. So thank you.
Thank you, Kyoko, for that. I think that also helps to answer our friend from Zambia. I think he has a question on the chat. I want to take this opportunity to invite the participating countries and their team leads to speak to the takeaways so that we can conclude. And I want to start with Côte d'Ivoire, and the translator can raise, so we proceed. Côte d'Ivoire,
Oui,
please.
bonjour,
Welcome.
Oui, bonjour, je suis Dr Dengra, chargé de la prévention au programme national de lutte contre le sida. Nous voulons remercier le réseau ainsi que le Kenya qui a permis cette session d'apprentissage sur la gestion des données pour les populations clés. Vraiment, ce fut une session très enrichissante qui nous donne déjà de dégager des perspectives pour améliorer la gestion de nos données en lien avec les populations clés. Comme je le disais, nous sommes encore au stade de fichiers Excel que nous transmettons aux partenaires d'implémentation avec beaucoup de difficultés sur la qualité des données, sur la cohérence des données, et parfois même ces fichiers Excel-là ne sont pas correctement bien renseignés. Donc, nous voulons migrer vers le DSH2 pour intégrer tous ces fichiers-là dans le DSH2, et le modèle que nous a présenté le Kenya pour nous comme perspective de pouvoir d'abord télécharger tout ce qu'on a vu comme outils, les analyser au cours de notre GTT, voir la possibilité de contextualiser, et puis après, via le réseau, contacter le Kenya pour continuer les échanges avec notre direction de l'information sanitaire, pour voir comment ensemble on peut migrer et puis définir un bon circuit de remontée de l'information. Donc, voilà ce que nous pouvons dire. En tout cas, merci au Kenya pour ce système très robuste qu'ils ont pu mettre en place. Et nous sommes vraiment très heureux d'avoir participé à ce webinaire. Et nous espérons qu'ils seront disponibles à nous accompagner pour aller jusqu'au bout dans l'intégration dans le DSH2. Merci.
Thank you, Côte d'Ivoire. I want to assure you, we are always willing to support our countries across the sub-Saharan Africa. You are welcome. Thank you for those comments. I move now to our next participant from Mozambique. Our friends from Mozambique, you are welcome.
A todos. Conseguem me ouvir?
Yes, we can hear you.
Ok. Nós como Moçambique, estamos muito felizes por termos participado desse exercício de partilha de experiência no âmbito da população-chave, sabendo nós que essa é um grupo bastante desafiador quando falamos de sistema de monitoria e avaliação, para podermos captar aquilo que realmente está sendo feito ao nível das comunidades. Nós temos um plano estratégico que contém tem um plano de monitoria que traz ao DC lá intervenções claras e sobre a população-chave, mas também gostaríamos de dizer que nós, como Moçambique, já implementamos a segunda ronda de BBS. A primeira ronda foi em 2011, 2014, e em 2019 conseguimos fazer a segunda ronda de BBS para mulheres trabalhadoras de sexo, homens que fazem sexo com outros homens, pessoas que injetam drogas, mas também transgêneros, e já temos relatórios para estes 4 grupos, e também, à semelhança do que foi dito antes, uma fonte muito importante que nos dá uma direção sobre o porquê de termos que olhar para este grupo com especial atenção são os resultados de modos de transmissão, que indicam que cerca de 1/3 das novas infecções acontecem em mulheres trabalhadoras de sexo, seus clientes e parceiros de seus clientes. E também temos feito aquilo que é a atualização do mapeamento, né, destes grupos, principalmente através dos parceiros que estão a fazer as intervenções ao nível das comunidades. E grande parte destes parceiros, eles estão a trabalhar nesse momento com o financiamento do Fundo Global, mas também temos uma grande parte de fundos que vem do PEPFAR. Temos também feito, ao nível de Moçambique, aquilo que é o exercício de estimativa de tamanho populacional, e estamos neste momento a atualizar aquilo que é o Keep Workbook, mesmo para alimentar aquilo que são as estimativas de HIV no módulo de população-chave. Então, achamos nós que, em termos de fontes de informação, nós, como país, ainda temos muito a fazer, uma vez que, em termos de ponto de dados, uma boa parte de dados que nós temos são dados com mais de 10 anos, porque, como dados atualizados, neste momento, para informar aquilo que são as intervenções, só temos a segunda ronda de BBS que fizemos há pouco tempo, mas também temos um estudo que fizemos sobre população-chave, que foi implementado mesmo pela sociedade civil, para estimar aquilo que era a prevalência, e também estimar o tamanho em algumas províncias do país. Então, achamos nós que ainda precisamos implementar mais estudos, né, para poder informar essa área. E, do ponto de vista de políticas nacionais, nós temos, sim, uma diretriz de população-chave, e essa diretriz da população-chave, ela é operacionalizada através de um POP, a SOP, de população-chave, principalmente para intervenções comunitárias. E temos ainda muitos desafios no que concerne a fazer aquilo que é a distribuição, principalmente de pessoas que injetam drogas e homens que fazem sexo com outros homens ao nível distrito, mesmo porque, tendo em conta aquilo que são as características do nosso país, esses grupos são grupos que têm características meramente urbanas. Então, há um exercício que está sendo feito ao nível de Moçambique através do grupo técnico, né, que é responsável por decidir questões relacionadas à população-chave para podermos avançar no sentido de harmonizar as ferramentas, como Quênia está muito avançado, né, porque já tem ferramentas padronizadas, que são usadas pelos parceiros comunitários, também são usados pelo governo. Nós ainda estamos no processo de elaboração dessas ferramentas. Relativamente a Código Único, nós, como país, ainda não temos padronizado também a utilização do Código Único, principalmente para a população-chave. Temos parceiros que estão a usar, que estão a atribuir códigos únicos à população-chave, mas não de forma padronizada. E, de uma forma geral, é isso que nós gostaríamos de partilhar, e esperamos poder receber os documentos que foram aqui apresentados para podermos estudar e replicar ao nível de Moçambique. Obrigada.
Thank you, Mozambique. And just to remind you, there's a link that was shared in the chat. Please pick it and follow up with us in case you have a challenge so that we support you to access the documents. At this time, I want to welcome our friends from Nigeria to give our takeaways, and then we proceed. Nigeria, it's your time. Our team leads from Nigeria, proceed.
Okay, good afternoon, everyone. My name is Edwin Chendru. I bring you greetings from the Director General NACA, Dr. Temitepe Ilori, who has just been appointed recently. She resumed to able. And on behalf of Dr. Community Prevention and Services Department. I don't know if you all can hear me. It's clear. Okay, so thank you. We operate same program in Nigeria. For us in Nigeria, we have done the KP size estimates. We have also done an IBS test in year 2020. Initially, we had size estimates for 7 states. For us in Nigeria, we have states plus the city. So initially, we did size estimates for 17 states. But 2 years ago, we completed our size estimates. So we have size estimates covering all 36 plus 10. We also have a KP secretariat in place. Most recently, last year, we finalized on the non-health sector tools, which is expected to be used for data generation, which is expected to be used to generate data that will guide evidence for our KP programming in Nigeria. We have a key population consolidated HIV guideline in place. Before now, we were programming for 3 KP typology: the sex workers, men who have sex with men, and people who inject drugs. But the last IBBSS, which we did in year 2020, also revealed that we have high prevalence for transgender persons. And again, we did a prison survey that revealed very high HIV prevalence for people in custodial centers. So we have 5 KP typologies we work with in Nigeria, covering all the 5 that I already mentioned. The consolidated line was finalized just recently, and it covers all 5 KP typologies. One that stood out for us in Nigeria is the theory of change for KP programming. Is one area that I would like to learn more, and will appreciate if other information on this is shared with us so that we can also replicate this program. It was interesting to know about different challenges regarding human resource. We are also experiencing challenges in Nigeria regarding human resource. So for our data, we use the same EMR and DHIS. And we have a national prevention technical working group where we have other subcommittees, and the KP subcommittee is also part of our national prevention working group. The KP subcommittee meets ahead of the National Prevention Technical Working Group, and they make presentations at the MPTWG as well. So thank you, the Kenyan team, for taking us through this. We hope to learn more from your experience. And like I said, we will greatly appreciate if the theory of change is shared with us. Thank you and over.
Thank you, Nigeria, for the remarks and the takeaways. And we are happy that there is some work already going on in your country to just build on it. I want to lastly invite Uganda, the team lead for Uganda, to speak to us on their takeaways, and then we finalize. Uganda?
Yeah, thank you, colleagues, for the presentation. This has been a very good presentation and the engagement. As a country, we also have a national monitoring system for KP, which started around the 2007, and currently we provide the ART in over 2,000 sites, and this system for reporting, monitoring program work is in around 600 facilities. The only difference that right now we have a different system which was initiated by PEPFAR METS. It's called the KP tracker, where all indicators are tracked. We also provide the services both in the community and facility, and we do have facility tools. Currently, we're also developing community tools because there are some other services that are given by our peers or the CSOs that are not reported through our KP tracker, which is a PEPFAR system. So the data which is generated at facility level is straight away goes to the national level. And us as government, we are able to report and pick on the indicators. But we've gotten challenges, especially when we signed the anti-homosexual bill, our government assented to it. PEPFAR stopped data collection and it wasn't mandatory. And yet for us as a ministry to be able to track the epidemic, we needed to report on these indicators. So we've started we want to have a national system. We've had talks with the DHIS to have at least a portal within the national system where we can also ably report. Just like any other country, we've had several surveys where we pick data, especially on the prevalence. Here in Uganda, we have brain survey, it is still ongoing. We've also piloted what we call biobehavioral study light, where we're able to generate little information. We hoped that we could scale this up, but this is when, as a country, we got challenges. Otherwise, this is a very good initiative. We also want to have it in our national system. Thank you, Kenya, and the other colleagues for presenting. Over to you, team. Thank you.
Thank you, Uganda, team lead, and all the countries for their contribution and for the takeaways. Right? I want to invite the team from SSLN for an announcement, and then we close. We have taken at least about 15 minutes. So at this time, I welcome the SSLN team, Lakote and the team, Karabo. If you have anything to announce so that we proceed, and we thank you very much.
Thank you, Ruben. First of all, I would like to thank our Kenyan team for that really comprehensive presentation. I'd also like to thank our participants from Cote d'Ivoire, Mozambique, Uganda, and Nigeria for your engagement in this session. The SSLN will be sharing the recording and other materials from this session on our website. And we're also happy to support any follow-up discussions with the participating countries on how they can apply the learnings from this session into action. And lastly, we're also happy to facilitate any follow-ups bilaterally with our speakers. With that said, I would like to conclude the session. Thank you, everyone, for your participation.
Thank you. Thank you, SSLN team, and we thank everyone who was part of this, our facilitators from Kenya, and all the participants from the 4 countries. Thank you very much.
Thank you.
Thank you very much.